Okay, well, let's get started. I'm Allie Malik. I'm a registered dietitian and intuitive eating counselor at the dorm. I graduated from the Ohio State's medical dietetics program through the College of Medicine. My past experience as a registered dietitian includes working with individuals in inpatient and outpatient settings who are working to recover from a variety of medical conditions and disordered eating patterns. I'm so excited to be here facilitating this timely discussion during Pride Month, but obviously timely anytime during the year about how to help specifically transgender clients struggling with disordered eating. Just some light housekeeping items before we begin. This will be roughly 35-minute presentation. You will receive slides and recording after the presentation, along with all of our contact information in order to keep the conversation going. Please note this is being recorded for our YouTube channel. If you do not want your image to appear in the recording, you're welcome to turn off your camera, although we love to see your face and welcome questions otherwise. You will have an interactive discussion after the presentations, so please save your questions for then and feel free to enter them in the chat at any time. So again, I'm so excited to be here today with a presentation about identifying and treating eating disorders among transgender clients. We have with us therapist and PhD student Emil Smith, Masters of Social Worker and licensed clinical social worker from FEDUP, a collective of trans, intersex, and gender diverse people who believe eating disorders in marginalized communities are social justice issues. Their mission is to make visible, interrupt, and undermine the disproportionality, high incidence of eating disorders in trans and gender diverse individuals through community healing, recovery, institution reform, research, empowerment, and education. Emil is a genderqueer PhD student at the University of Pittsburgh School of Social Work and licensed clinical social worker in Pennsylvania. They have been a member of FEDUP since 2021. After working to support access to mental health care for LGBT transitional age youth in Minneapolis, Minnesota, they attended Smith College School of Social Work for their MSW. Through their work as a behavioral health consultant in primary care settings, they developed an interest in enhancing the understanding of eating disorders among trans-affirming medical and mental health providers. Their work is informed by anti-carceral, client-centered approaches to healing and recovery and a passion for relational psychoanalytic theory. Without further ado, I'll turn it over to Emil to help get us started.
Hi, it's so lovely to be here with you all, and thanks so much to the dorm for inviting me. Can we start sharing slides? Elizabeth is helping me out with slides today. So go ahead and go to the next slide, third one. Thank you. So you just heard my bio like multiple times, but I do think it's important to start a little bit by talking about positionality so we can understand like where I'm coming from and how like my identity and my life experience impacts my relationship to this material. So I was really led to this work through my work as a behavioral health consultant, but then I also ran and started an LGBT mental health IOP in Southeastern Pennsylvania during the pandemic. And I also have worked in outpatient private practice. So I kind of span like medical spaces, but also outpatient mental health spaces. And in terms of my current research, I specifically look at barriers and facilitators to care for trans folks who have eating disorders. There's a lot of things that goes into that, but that's where I'm at right now. And I identify as white. My parents were both trained as physicians, which also impacts how I move in these spaces, especially medical spaces. I'm from a very rural area, and I grew up with a sibling on the autism spectrum, and living in a very rural, isolated area in the early 90s with a young sibling with autism was definitely an experience that also kind of informed, how I understand a lot of mental health stuff and medical stuff. Next slide, please. So we're just going to start off with some 101. So a lot of this might be familiar to you, but we're all coming from different places. So gender, we're talking about transgender, someone who does not identify with the gender they were assigned at birth. And cisgender is someone who does identify as the sex they were assigned at birth. So, if you're assigned female at birth, your genitals look a particular way, society assumes that you will then grow up to identify as a girl and then a woman. That's not the case for everyone. Next slide, please. So I also, you see the acronym TGD. I use the word transgender and gender diverse. And part of why I do this is that there's like many gender identities that fall outside the identities of man and woman. Non-binary is one that people are very familiar with, but I try to remind people that non-binary isn't like this third gender that exists in this middle space, but is one gender that sometimes is used to encompass many other gender identities, such as gender queer, gender fluid. There's a lot, and it's always being updated. You can always look on Wikipedia and see what people have added. And then one thing that's important is some people who are not cisgender might identify just as a man or woman or girl or boy, and not a trans person, but they'll identify as a person who's had a trans experience. And then one example of how language is evolving is that it used to be really common in trans communities in the early 90s and the 80s to use or even later 90s to use MTF and FTM. That's kind of mostly no longer used because it emphasizes sex at birth, so it's felt as like gender essentialist. So that's just one example of something that used to be very widely used and accepted by people in the trans community that has kind of like fallen out of use. Next slide, please. And at FEDUP, we also are a collective of intersex folks, which I feel like is important because it often is like stuck in there with the rest of the LGBTQIA population, but most people don't know a lot about intersex folks. So it's important to recognize that biological sex is also a spectrum. Intersex traits might be apparent at birth, but they sometimes show up at puberty or even later. And people, there's like, they say about up to 5% of the general population has some kind of intersex trait, which is a lot higher than, how some people have thought about it before. And I think one word that can be important is the word endosex. So people who have physical sex characteristics in alignment with binary sex norms. But yeah, there's lots of different ways to be intersex. And unfortunately, intersex people experience a lot of bad things in the medical system, starting from at birth with non-consensual surgeries all the way through life, like continuing to see medical providers who have little to no training about their bodies. Next slide, please. So how do I talk about trans people? I always say mirror the language that a person uses for themselves, if you can. That's the best thing that you can do. And it also is important to practice. So for example, like if you're trying to use someone's pronouns to their face, especially like they, them pronouns or pronouns that may not align with your expectations of what their pronouns should be, but then when you're not in front of them, you use the pronouns that you would assume, that can be really complicated because then you're more likely to mess it up when you're talking to people to their face. And there's lots of opportunities to practice. www.pronouns.org is a great resource. And then some examples of like language that sometimes people accidentally use. They're not being malicious, like no bad intentions, but can be experienced as pathologizing, is saying that someone is transgendered. Instead, we would say transgender or trans. And then Max is a transgender. It's a trait of a person. So Max is a trans person. The thing that I hear a lot that I still get, in academia, in my doctoral program, where everybody has had these trainings, is like, oh, your pronouns are so hard. Like I learned English a particular way, so don't get mad at me if I mess up. And that's as a as anyone, like even as a cis person, if somebody said that to you, that's like very uncomfortable, because it kind of puts you in the position of needing to take care of the other person's feelings and being like, it's okay, I know you're not a bad person, when really you can just try your best. And the reality is that we all make mistakes. So you can just correct yourself, be like, oh, I'm sorry, I meant they, or I meant she, and then kind of move on. Yeah. And let's go to the next slide. And I hesitated on whether or not to include this slide on here because some of this language is incredibly offensive. But this is some language not to use. I think on here, you know, people saying transsexual, that's not a word that we really use anymore. Hermaphrodite for intersex folks is basically always pejorative. Sex reassignment surgery is no longer used. And then saying preferred pronoun or preferred name, we don't use that because it's not a preference, it's just like the name and pronoun people use. So just asking for name and pronoun, not preferred, is the best way to do that. Next slide, please. Okay, so what does it mean to transition? So I think we have an idea of what this means based on, you know, Transparent and all of these like TV shows and stuff. But it's important to recognize that transition is not always medical. And that is for a few different reasons. One is because not every trans person wants to medically transition for a bunch of different reasons. One reason is that some people cannot access medical transition, especially in some states, as states are restricting access to trans-affirming medical care, especially for youth, but also for adults. Less and less people are being able to access that care. Medical interventions for transition don't have to happen in any particular order. Sometimes surgeons do have requirements if somebody needs to be on hormones for a certain amount of time before they do a certain surgery, but generally there doesn't need to be an order. And then that there's no medical interventions that make someone more trans than other trans people. Next slide, please. So here's different ways to transition. One is social transition. So that's like being seen as a particular gender in your life or in your family, you know, in school. That's one thing. So a lot of times that means like someone changes their name and changes their pronoun, but may not legally change their name or pursue medical transition. Medical transition is often what we think of when we think of transition. That's like gender-affirming hormone therapy, gender-affirming surgeries. Legal transition that involves, you know, changing your name legally. Usually people have to go to court for that. It typically costs money. There are some grants now available through Trans Lifeline for folks trying to change their name. But it's quite a process that is not accessible for some folks. So yes, there's no full transition, but there's many different ways to transition. Next slide, please. And so one question that we get a lot with eating disorders is like, okay, well, how do we tell what's gender dysphoria? How do we tell what's body dysmorphia? What about body dissatisfaction? Like how do we parse all these out with trans people? And so just to start with some definitions, gender dysphoria is talking about the discomfort and distress that someone feels because their experience of their gender identity feels different than how they are perceived or how they perceive themselves. Body dysmorphia is a little different, but can be experienced along with gender dysphoria, and people can't always tell the difference. And that's distress due to one's own distorted perceptions of their body. So, you know, it can be something like, oh my God, my knees are so fat, or blah, blah, blah. But it can also be something about there's many ways to have body dysmorphia. Body dissatisfaction, feeling worthless due to your body or really disliking your body. That, as you can imagine, can also intersect with gender dysphoria and body dysmorphia. And then I really wanted to also put in here gender euphoria, because so often when we talk about trans people, we talk about all of the negative experiences that come along with being trans. And as providers, it's really important to leave space for people to be able to share their positive experiences that they're having in their life, whether it's like their job or their friends or their relationship, and also like moments when they felt really good about their gender, and let them kind of like have that time, because that's also an important resource for people to come back to in moments of feeling a lot of dysphoria. And I think it's also very tied to recovery from eating disorders. Next slide, please. Oh, one other thing, sorry, go back one slide. Sorry. One other thing that's important is not all trans people experience gender dysphoria. So it's really important to listen to people when you're talking to them, rather than making assumptions like saying, how long have you struggled with your body? That's not going to be experienced as a nice question for a lot of people. And then the other thing that I wanted to highlight is that dysphoria also has this very strong relational component. So somebody can look a certain way and feel okay by themselves. And this was an interesting thing that happened during the pandemic in terms of people's experiences of dysphoria and euphoria. But then when they are inserted into a family or a classroom in which everybody is using the wrong pronouns and not saying their gender is valid, that substantially exacerbates gender dysphoria. So it's not just about like what the physical body looks like. Okay, now I'm ready for the next slide. So why are trans young adults uniquely at risk for eating disorders? One, their coping strategy, just as they are for cis people. And trans people experience a lot of, we call gender minority stressors, or trauma related to discrimination. And so disordered eating behaviors can be a way to cope with those experiences. Trans adolescents and adults, honestly, can use disordered eating behaviors to suppress secondary sex characteristics if they don't have access to gender-affirming medical care. This is one of the things where I'm like, gender-affirming medical care at puberty is incredibly important, because a lot of trans folks find that experience of puberty incredibly dysregulating. And that's when we see a lot of these disordered eating behaviors start to happen. Safety is also important. So, it's not just about being vain. It's also about like certain, trans people, if they look more in alignment with the assumed gender binary, they are probably going to experience less discrimination. Not for sure, but it is a strategy for staying safe. Another thing is that many gender affirming surgeons have BMI limits for the surgeries that they will perform. Like, they won't perform a surgery on anybody with a BMI of over 35. And so a lot of times trans young adults feel like they have to lose weight by whatever means necessary to access the surgery. And then finally, there's been research in trans populations and then also in the general populations that financial insecurity and food insecurity are deeply tied to disordered eating. And that's for a lot of different reasons, but trans folks do experience higher rates of financial insecurity and food insecurity as a result of discrimination in society, kind of a downstream effect. Thank you. So yeah, you probably got this by now, but eating disorders may not resolve with medical transition alone. A lot of the first research about eating disorders in trans people had this argument like, okay, yeah, let's give them access to care and then the eating disorder will go away. And that's it's really important to have access to care, but it's only one part of the entire equation. One thing is that you don't get to choose what happens when you start hormones. It's kind of a roll of the dice. You don't know what's going to happen. Body fat moves around. That might be triggering for folks. Eating disorders are still a coping strategy. And that transition is not necessarily a cure for eating disorders. Next slide, please. Okay, so this is also really important to get across because, we hear this now, eating disorders don't have a look, but as clinician, it's kind of important to recognize, like, what are the kind of things that like make your head, like the light bulb go off, like, oh, maybe there's an eating disorder here. And a lot of times for us, that has to do with body size. So we think about eating disorders when we see somebody who's very underweight or someone who's overweight. Yeah, so this quote, I just feel like is very, or the stat is very, illuminating about adolescents with a history of being overweight or obesity represent about 36% of patients presenting for treatment of serious restrictive eating disorders. And that's even important because most people who have eating disorders don't access treatment. So a lot of people who have a history of being overweight, or might be currently overweight may also be engaging in disordered or in really severe restrictive patterns, which can cause malnutrition, and, all the way up until death, lots and lots of health problems. Next slide, please. So one example is atypical anorexia nervosa. I put atypical in quotes because I'm like, how atypical is it really? I think the more we learn about eating disorders, the more that we learn that atypical anorexia nervosa may not actually be very atypical. It may actually be the typical. And this I also talk about a lot because medical providers are typically trained to treat obesity, but not restrictive eating patterns. So this is often missed. These folks take longer to be identified. A lot of times they're more resistant to treatment because they get a lot of positive messaging from their family, even their medical providers about, losing weight. And so as a result, there's more severe psychological complications and symptoms. And like I said, they experience many of the same kinds of physical, medical problems that result from malnutrition. Next slide, please. Okay, so this is more about what we need to do as clinicians to actually do this work. I think oftentimes we kind of think about like, okay, what are the things I need to say or I need to do for this client? But so much of our ability to have these conversations has to do with our own comfort in talking about these issues. And all of us were raised in this society. The last 20 years have been the war on obesity. We've all been raised with that public health messaging. We all consume this media. So, none of us are kind of immune from internalized fat phobia or, these negative, I'm going to say negative, but Eurocentric like beauty ideals, gender ideals, all of that. So these are just some questions to ask yourself about your own experience of your body. A lot of the time when I brought this up with medical providers and was trying to train medical providers about how to have these conversations with patients, they would get to the part where they're like, how's your relationship with food? And somebody would disclose, some kind of not great relationship. And then the medical provider would be like, okay, I don't know what to do. And kind of like be caught like this dog, right? And be like, I don't know what to do. And part of that is lack of training, but part of it is like, all of our own stuff, and eating disorders are also one of those things that can kind of come up like a huge, like hot potato issue of like, don't want to deal with it. It feels scary. But I think that we also need to recognize this kind of stuff going on for ourselves, because I think it's important to recognize that we are not immune from this. And medical providers and mental health providers also perpetuate a lot of the kind of like health ideals around and weight stigma that contributes to the maintenance of eating disorders. Next slide, please. And I'm seeing this comment from Laura. As someone hospitalized for anorexia, I had to fight to convince others this is what's going on. Still got my period, etc. Lots of discrimination. Yeah, and I mean, I think this is a huge problem, right? As people are seen as not sick enough because they don't meet these check boxes, or they experience themselves as not sick enough. And so then they don't recognize that treatment is actually needed and that their concerns is valid. It's really easy for someone always to have it worse than you, especially when you've been told, like, well, you lose your period when this happens. And that's another thing I think that's particularly true for trans folks. And the importance of period blockers for some people is they will engage in disordered eating or restriction to stop their period. So we need to give access to period blockers for those folks. And sometimes people are like, well, how do I know that you're not just using this to mask your eating disorder? It's much more complicated than that for trans people. And those are conversations that need to be had where the patient really needs to be listened to and trusted. Okay. Just going to have to start speeding through these. So yeah, open conversations about relationship with food from the beginning. So kind of like making space in the original intake to kind of have those conversations and continue those conversations throughout your treatment relationship. I think in working with adolescents and young adults, like thinking about family is really important. Family norms around food are often the origins of a lot of disordered eating patterns. You know, people are saying, oh, it's one of my goals to eat healthy. What does that mean to eat healthy? You know, sometimes that means, you know, drinking a lot of water and chewing gum and exercising a lot and eating an apple. And, you know, we just need to have real conversations about what that means. And then, like you've probably already gotten across, weight loss does not necessarily equal health. I think it's important to think in terms of health promoting behaviors, like exercising a certain amount or eating a certain amount of vegetables, rather than like, oh, well, you know, you need to lose weight to like help your knee pain or whatever, when actually the knee pain could be maybe helped with, you know, more mobility stuff. And often like, okay, I'm just going to skip ahead. Next slide. Thank you. So yeah, talking about prevention. So I feel very strongly about prevention because eating disorder treatment is really inaccessible and it's often a terrible place for trans people. So unfortunately, there's no screening tools specifically validated for trans populations, but some have been partially validated, like the EDEQ, EDEQS. I just saw one yesterday that came out around ARFID, which is avoidant restrictive food intake disorder. So that's one thing just to keep in mind, that it might be helpful to use those, but kind of like gently, and also ask kind of like qualitative open-ended questions. And screen for food security and provide resources. That's really important. I think we overlook that a lot. You know, as people are talking about transition related goals, and as you're maybe supporting someone in their transition, it's also important to think about like food. And oftentimes it might be important to talk about, you know, the role of adequate nutrition in hormones being able to do their job. You know, if you're not eating enough, like your testosterone that you're taking is not going to work the way you want it to. Or if you're not eating enough, then you're not going to heal from surgery. You know, you may have more complications. And these are important conversations to weave in to talking about gender affirming care, or even people trying to change their bodies. And then also like, you know, really talking about ways to deal with stress and provide trauma-informed care, which you all know seems very basic. I'm kind of also just saying this to be like, probably some of the things you are doing are also eating disorder prevention. It's just, we need to like put this additional lens on there and be having those conversations. See, yeah, so supporting clients. You guys, I'm really happy you all are here, because I think one of the big things is educating yourself, and this is a very small amount of time, so I'm going to leave you some resources. I think as much as you can, educating yourself about, you know, trans identity, trans experience. I think also really paying attention to the policies that are being enacted on the state and federal level, where some of these court cases are, a lot of my clients, that's what they want to talk about in their therapy sessions, because it is a real stressor for people. And it's important as someone who's supporting trans clients to also be aware of what's happening in that way. Build support systems. So this is like connecting folks to peer support. FEDUP has support groups. I believe they're on pause right now, but we have resources for some other ones. Recovery coaches, if somebody has the financial means, can also be really supportive. And then building care webs. So this feels important also to kind of support folks kind of before or, after hospitalization. Hopefully they don't get to hospitalization, but who are the like friends that you can that you can lean on? Like, is there a way that we can bring in your friends or your family to kind of like talk with them about what's going on and think about ways that we can like, that they can concretely support you. One thing that feels incredibly important is assessing the trans competency of any referrals you're going to be sending people to, because one, behavioral health organizations and mental and physical health organizations, there's tons of turnover. Something that was good at one point may no longer be good. They might have been also like okay for this trans femme person, but maybe not okay for this trans masc person. So calling ahead when you're about to refer someone, and being able to kind of be transparent with your client or patient about what they should be able to expect is really important, because the reality is trans people don't expect positive experiences when they're going into medical or mental health care. And so being able to identify a point person they can talk to or whatever, it can be really helpful. And then harm reduction. So I don't have space to really get into eating disorder harm reduction today or harm reduction overall, but harm reduction came from drug users who are trying to find ways to reduce harm caused by their drug use and survive, basically. So it's a movement for social justice, built on a belief in and respect for the rights of people who use drugs. But in this case, I'm talking about eating disorders. So a lot of times people with eating disorders, especially those who are really sick, their eating disorder becomes the way that they are seen by the entire world. So I think finding a way to keep the person kind of at the center, and like respecting their autonomy as much as you possibly can and listening to them, rather than, I think with folks with eating disorders, it can really quickly become adversarial and then non-compliant, when we consider people as non-compliant. And then also, it can be good to have an idea or like about what labs need to be done. And so, eating disorders do not always show up on labs, but that is one thing that, primary care providers in particular can be running at certain intervals to kind of like medically monitor folks who are not going to go to treatment for whatever reason. One other thing just about building support systems is FEDUP has a treatment center scorecard where we talked to a bunch of different treatment centers and kind of scored them on their trans competence. Next slide, please. So more considerations. Access to gender-affirming care is often essential. We talked about this. Every person's recovery looks different. Also, the concept of recovery is hotly contested, because sometimes it's like, well, do these behaviors ever really go away? Do these thoughts go away? It's just different for everybody. And then I think, I brought up treatment resistance. It can be really frustrating to work with clients with eating disorders. I'm just going to name that. And it's also really frustrating to be a person with an eating disorder. And so really if like you come away with anything, it's kind of trying to like remove treatment resistant from your brain and instead be like, okay, well, what's going on for this person? Eating disorders are really difficult to treat. There's such limited research funds that go into treating eating disorders. There's a lot of reasons why it might not be working. A lot of eating disorder treatment is also experienced as traumatic for many reasons. So, and then the final thing is like, you want to meet people where they're at, which they might lose hope completely, but as a provider, it's important for you to continue to hold that change is possible. You know, like as I've been doing this work and meeting more people, there's so many people who are like, you know, on palliative care for their eating disorders. And then at some point something happened and they were like, you know what, like I'm going back to treatment, like I want to do this. And that is always a possibility. So I'm just saying, don't give up, because people with eating disorders are used to people giving up on them, especially trans folks who have had really negative experiences in treatment. So just a little bit around kind of eating disorder treatment and how we might shift some of our language in working with trans folks. We might move away from body positivity to kind of body neutrality or body liberation. This also goes for people with chronic pain and health issues. You know, if a trans person is often trying to like change their body, or like their body causes them harm in the world because of how it's perceived, asking them to feel positive about it may not be possible. And so just moving towards like body neutrality, and accept, like knowing that like, yes, this is my body, this is what I've got to work with, this is my form on this planet right now. You know, some people are like my meat sack, you know, like whatever, just to get people to just be like, yes, this is my body, I have a body, I don't need to completely disconnect from it, because a lot of people won't want to just completely disconnect. And then instead of talking about the thin ideal for trans folks, we're also talking about gender ideals. And then I also put Eurocentric beauty ideals on here because I think that's also part of it. And yeah, something that is not talked about enough in like eating disorder treatment. And then, you know, a lot of times people are like, oh, you don't need to change your body, like you're perfect just the way you are. But changing that to be like, yeah, bodies change. Bodies might need to change. And like, we need to accept that bodies change. And this is actually setting them up for like healthier long-term kind of health and eating disorder recovery, because then they're not, you know, it's just real, like bodies do change. We get older, things shift. See, next slide. So you all will like have this is just like a start of some resources. I like started putting more, and then I was like, you know what, let's just start here. You know, these resources will lead you to many other resources. And that's what I have today. I know that we didn't get deep into a lot because, you know, we went through eating disorder 101 kind of and trans 101. So I'm happy to answer any questions that you might have. There were a few questions that were submitted prior to the starting. So yeah.
Thank you so much, Emil. That was so informative. And I just want to edify all the work that you're doing. And with FEDUP Collective, it's been so helpful for a handful of our clients. And that's why I'm so excited to be doing this with you right now. So thank you so much for taking the time to educate us further. If we would love to open the conversation for questions, if you feel comfortable to unmute and join in the conversation. We did have questions. If anyone has a question, feel free to post it in the chat or ask by unmuting yourself.
I saw that Honey had a question.
Yes, hello. I didn't want to intrude. Hello, everybody. First of all, apologies for arriving late. I couldn't find the Zoom link. I can't even blame technology. Thank you, thank you, thank you. I always love when there's a 101 and a refresh and a reminder. One of the things that comes to mind, she said, as she's writing, get out the vote cards for our rights across the United States. As a clinician, one of the things that comes up regularly with various communities, populations, and I say this with respect as a foreigner, as a guest in this country, the issue of religion and how religion can have an impact on an additional layer of impact, along with what we're seeing now with the federal, the state, the health insurance, all those good things. And I often wonder how that is experienced by other clinicians, interventions, thoughts. It's just something that comes to mind. I'm not used to dealing with religion as a major factor of treatment, but again, respectfully understanding that in the US, it has more of an impact. And I don't want to use the wrong word here, but I just would love to hear thoughts around what people are experiencing with that subject as an additional intersection.
I'm happy to offer thoughts, but it also feels like a question that's being posed to the general audience. So I feel like if you all want to put stuff in the chat about your experience, I think that would probably also be really helpful. I think specifically in working with trans folks, like a lot of, especially if you're working with trans folks who are connected to their families still, there can be a lot of pressures around religion and sometimes like a lot of confusion around religion. Especially for folks who do strongly identify with their religion, but then somebody in their religion is telling them it's not okay for them to be who they are. And that just kind of adds like another layer to the work, I think. And I think, you know, I've talked to a lot of people who have made their own like spiritual paths because of that, but it does often stress family relationships. And sometimes even with families who are really supportive, then it's the family who's kind of experiencing the stress in relation to the religion. So that's not really like exactly saying like what to do, but just saying it adds another layer and can make things a little bit more complicated. And then for some folks, you know, like they have great experiences with their religion, you know, and there's a lot of religions that are very trans accepting. So just really depends, I think.
That is great to hear. Thank you so much. I know we don't have a, you know, just use that intervention and that fixes everything. But it's good to hear that experience and good to hear that there are some spaces that are spiritually welcoming.
Mm-hmm. And, you know, there's always Googling. It might be helpful to like Google, like, you know, trans people with negative experiences with religion and see if there's some kind of support group or something. Because I know some people who are doing that work as like educators and academics. And I know that there's some, you know, trans clinicians, therapists who also like that's been their life experience and that's something that they bring to their work with clients.
That's a great resource. Thank you. It didn't even occur to me to do that.
Laura, you've had your hand up.
Hi, I just wanted to say thank you for all of this. And I had put in the chat, so I am a white cisgender woman who faced severe discrimination in the hospital, hospitalized with anorexia. So I can only imagine if I did not fit in any kind of box, which clearly I didn't fit into the medical model. I was at Johns Hopkins Hospital, so which is also a medical model, which isn't helpful for anybody. But also to bring, it's important that you brought in the issues of the hormone therapies and the importance of eating, nutrition around that, what those present, what those may look like when someone is transitioning or making these decisions. And I did feminist psychoanalytic psychotherapy. So a lot of what we talked about was body image and the Eurocentric body. And that's something in this country that is pervasive. Our media, everywhere we go, you can never be, my mom said, you can never be too rich or too thin. So try growing up with that. So, you know, but that is our culture still. Even though there's more, you know, less body shaming, it's still around. So I think that it's critical to understand where the intersection between, you know, the trans community and eating disorders. So I just want to say thank you for making this an issue.
Yeah, and I just want to respond to a couple of things that you just said. Like, one, eating disorders don't fit well in the medical model, like you just said, like they really don't, especially when we think about obesity and weight as an indicator of health. But also, neither does trans identity, right? So trans identity has been highly stigmatized and medicalized, for a very long time. And still is, like, trans people, even when they go to their trans affirming primary care provider, the goal is reducing dysphoria, right? And so yeah, I just, it's a double kind of whammy when we're talking about trans folks with eating disorders trying to navigate the medical model. And then the other thing that I wanted to say is, that's like kind of a caveat with a lot of this, is that the research about eating disorders in trans populations is incredibly new. And so there's a lot of things that we don't fully understand. So we can like extrapolate from what we understand about like cis people and hormones and eating disorders, but like how that exactly shows up for trans people, like we don't actually know. And yeah, TGD means transgender and gender diverse. So that's encompassing people who identify as trans, and then also people who have a trans experience, but may not identify as trans or also identify outside of the gender binary. Long explanation, but yeah, so hopefully we can shift this and start doing more research about trans folks, so we understand some of this better. Any other questions? One question that I had is somebody asked, is it more common in trans men, trans women, or non-binary individuals? And it just depends on which study you read. It's like different in every study I read. So it's just pretty high across the board, basically. There was a recent meta-analysis that got published that was basically like trans people overall have like worse eating disorders than cis people, including cis women. And the studies that didn't find that, they found like methodological limitations, like wasn't eating disorder specific questions, or, they're relying on insurance data, which, the number of insurances that cover eating disorder treatment is one thing. Also, the number of people who are trans based on their insurance is another thing. And then also the number of people who access treatment is a whole other thing. So just wanted to say that. There was also a question about the intersections between autism and queer and trans identity, I think. And one thing that I just wanted to say is that, folks with autism are overrepresented in trans populations. There's not like an exact, like, we don't really know why. And I think how that intersects with eating disorders for me is thinking about avoidant restrictive food intake disorder and how that is very common in folks with autism. And so how some of these things can kind of layer. Yeah. And yeah, and the other thing just about body image is that I was going to say is that, the Body Project is something that has been used in gay men and cisgender women. And those are great programs, and they're trying to build one for trans folks. So I'm really hoping that that will happen at some point soon. So the Body Project is like a prevention program around body image and unlearning some of the like thin ideals and gender ideals and stuff like that. And was the study on the intersection, was that talking about autism and trans identity that you were talking about, or eating disorders and
neurodivergence and the LGBTQ plus community? Yeah.
Oh, cool. Yeah, that research is also very new. So yeah, any other questions?
I really appreciated when Emil, you spoke about coming out of the pandemic, and how do you think we can be supporting our clients more so if there's social anxiety and there's other layers right now.
Mhm.
Sorry, I just wanted to interject. I'm a trauma therapist, and we've gotten a huge grant to reach out to the LGBTQ plus community, and so, and eating disorders, I think research, but that is a very significant trauma response often. So, you know, different traumas, right? It's hard to distinguish which the traumas are, if they are or not related to one's identity. But it's important, I think, to see eating disorders in that light as well, as a very significant trauma response, a control, you know, how you want to be seen in the world, if you want to be touched or not to be touched. You know, it's a huge issue in the trauma community as well.
Mhm. Yeah, I mean, I would agree with that. One of my colleagues and I just wrote a chapter for a book called Trauma and Eating Disorders, and it's about eating disorders and trauma in LGBTQIA plus population. So who knows when that's going to be out, because I've learned that publishing takes forever. It takes a lot longer than journal articles. So I don't know what's coming out, but sometime it should come out. But yeah, that also there's just like so little, you know, there just when you're like thinking about eating disorders, you can like throw, like if there's a bullseye, you can like throw a dart and hit anywhere, and that place probably needs more research. And then you're asking about coming out of the pandemic, and I just want to validate that, you know, when the pandemic started, everybody's freaking out, and a lot of my trans youth were like, I'm doing great, like online school, like, you know, life on the internet, it's awesome. And like a lot of their anxiety and depression kind of initially plummeted, but I do feel like then there was some kind of like isolation that built up over time, and it's been really difficult to get people back into the world and back into like being perceived in person. And I think in terms of how we can support people, I think, you know, for people who are open to connecting with like supportive kind of community around trans stuff, that can be really helpful. You know, like seeing if there's programs in your area. I also want to recognize that some people are not going to be interested in doing that, which is also important to be like not forcing people to do, you know, like go to their local LGBT center or whatever. Yeah, I think I guess I just want to say it's something that I feel like I'm also struggling with as a clinician. And I'm working on it. I don't know. I think it's hard for a lot of us, but yeah, I think it's also just like for so many people, the pandemic was kind of a trauma that's like now being kind of like glossed over and not recognized by the world, like it didn't happen. And that is like a very dysregulating like experience for a lot of people, especially when some folks, especially folks who are in recovery from eating disorders, may be at higher risk of like catching COVID again and having medical complications from that. So I think that it's also important to kind of, you know, like recognize all of the complicated layers in this like this new normal that we live in. I don't know if that's helpful at all.
No, absolutely. Very helpful. Yeah, thank you again just so much, Emil. We will be sending slides out and information to continue the conversation. The dorm, like we're so grateful to have you and FEDUP Collective come today and give us more information and educate us. So thank you again for everything, Emil. We really appreciate it. And we'll just give you all the time at the top of the hour. So have a great day.
Thanks for being here. Have a good day.